you. My sincere apologies for this mishap. I'm going, we're trying to connect and nothing's happening, so I do really apologize. Look, first, apologies for yesterday. There was a problem with the Melbourne Cup, and some of our colleagues are in Melbourne, and they're organizing the webinar, and that was a holiday in Melbourne. So I took the opportunity, then, not having all the right, so when we had to make a decision, and we said, well, look, it's better that we do the lecture tomorrow. And this is only Wednesday lecture we'll be doing. Usually it's every second Tuesday. And in Tuesday week, we'll have Dr. Shane Gama, who issues the endodontics. She'll be talking about all the new ideas about endodontics and some of the very important aspects of endodontics. So I'll send that to you soon. Now, what I did yesterday, just to let you know, as you know, I like dancing tango, so I took off to my tango class, and so I had a fantastic evening with some of the dancers in the class. So just let you know exactly what I do in my spare time. I enjoy dancing, and that's really important to me. And I hope that you have the same way, and you dance and enjoy, and you have a spare time. So Melbourne Cup Day, I went to tango dance. It's Argentinian tango. This is my favorite areas. So back to the class. What I'm thinking is that the important part of today's meeting was to talk about free cases, and I'm going to go back to this. I'll come back to this later on. The free cases where we can have free patients. It's an open dialogue, and I want to get everyone's ideas. And I have not going to show you what I did for those patients because I haven't treated those patients yet. There are 3 new patients I presented in my practice this week, and basically it's an open session. And I want everyone's participation. So don't wait for me to talk. I'm going to make you talk. I want you to understand that. Now, there's a colleague of mine, Dr. Ravi, who was present in one of the patients, and he could see. Is that right, Ravi? You were there. Who could see how we interview patients. So, having said that, this is patient number 1, and you have 3 patients. There's these patients come at different ages. This particular patient is female, and she's 57. My question is, what do you see in this patient? And please talk to me. There's no right or wrong answer. We want a dialogue. I want everyone to think. And that's, if you don't, I'm going to look at anyone's, I would say, look everyone's names. I'm going to pick somebody up. So please tell me, what do you see when a patient first presents in your practice? Go ahead.
I see spacing.
Go ahead.
I see spacing.
Spacing. Okay. Very good. Whereabouts is spaces? If you describe it, that'll be fantastic. So where do you see the spaces?
The most obvious one is the space between the upper anterior teeth that looks like they are moving or flaring out.
Okay, so you're seeing spacing between a 2-1 and 2-2, correct? Is that what you're seeing? Or between 1-2 and 1-1?
As well.
I didn't hear you, I'm sorry.
Yes, 1-2, 1-1, 2-1, 2-2, and possibly between the 2 and the 3.
I see. Okay. I agree with you. I agree. What would your initial, you've seen the patient first time, and the patients look, basically I can see the space appearing. What would your initial concern be for this particular patient who's 57, female? And what would you say to the patient?
Has your teeth always been like this?
That's right. Very good. Very good. Very good. If you look further in this picture, because I specifically chose the images in a way to confuse everyone, and that's usually the way I like to do things, but it's thought processing, so thought provoking. What else would you see here when you measure spacing? Do you see anything else, like just from the image? Because I'll show you the next image, sure. Is there anything else that you see?
There are a few comments, Dr. Sarkis. Jesse Holt is saying there is an overbite.
Right.
Mikhail is saying 22 as big as 21.
Right, right. Okay. Anybody else can see anything else here?
There's a partial denture there.
Partial denture? Where is the
Mhm.
partial denture?
Well, I could be guessing. It's on the top. That tooth number, maybe 1121 and
22.
22.
Mhm.
Yeah.
Okay.
It's somewhere there.
Somewhere there. Well, fair enough. It's fair enough. You know what? It's a start. Okay, it's a start.
And there's another comment
It's over up.
from Genus, missing upper molars.
Right.
Kanravi is saying overruption.
Mhm.
Over eruption.
And sorry.
Jesse Holt is saying bone deficiency in the lower arch.
Mhm.
Rekha is saying deep bite and traumatic bite.
Mhm. Mhm. Why would you say, Jesse, I understand what you, but why would you say it's a bone deficiency in the lower arch?
Because you can see that the teeth are missing at the bottom posterior and the recession, and you can just see it's all caving in.
So you're saying bone deficiency, what do you mean?
She's probably got perio disease in the lower arch, and if she's got it in the lower arch, it's probably in the upper.
When you say bone deficiency, you're saying in terms of this lack of bone to do further treatment? Or what do you mean? I just wanted to clarify, that's all.
Yeah, there's not a lot of posterior support for the occlusion.
Okay, so it's not real bone deficiency, you're saying there's not enough support, is that be correct?
Well, there isn't a lot of bone. You
Well,
can see all the recession on the left-hand side.
okay, you say there's not enough teeth there, is that correct? And because there's not enough teeth, you're saying there's not enough bone, would that be correct?
Correct, yes.
Thank you. I just want to clarify, because when you say there's a bone deficiency, we sort of tend to assess the bone more with the X-ray. But I understand what you're saying.
There's a bone deficiency because the teeth are missing.
Yes, I agree. I agree. But generally, we look at the bone in terms of X-ray, and we look at the teeth. But you would say there's a lack of teeth, okay, and there's a lack of teeth on the posterior segment. Do you see anything else that will start to say, I wonder why this teeth, there's a spaces here? I mean, that's always a composite build-ups. You can see it, right? There's a composite to close the diastema. Do you see anything else here?
Dr. Sarkis, Mikhail says irregular gingival line, and Lillian says deep bite over eruption of the posterior molars.
Okay, deep bite eruption of posterior molars. Okay. Let's think about this. Very interesting. Okay, this is an interesting picture, you see. I specifically chose this image to show because just to tell you that eruption, it is a low eruption. And does anybody know why there's no eruption in this case?
We have another comment, genius, I think that's, I don't know if I've, incompetent lip. And Mikhail says again, no occlusal stops.
Okay, so which teeth have all erupted? Anyone? Which teeth? We all agree that there's no eruption. Which teeth have over erupted?
We can see 3-7 at the back. There's maybe even from the view, I think and even 4-7 at the back.
There are some comments.
Yeah, Dr. Sarkis, Khan, Ravi.
Lower molars, like in lower post. Okay, fine.
Lower molars,
And the
lower
1-2?
sevens.
Sevens. And
The 1-2?
The 1, 2 overrupted. Let's look at, okay. You think it's overrupted? I don't know. I'm just asking the question. There's no right or wrong answer. I just want to get the dialogue going, because I think this is a very important lecture today. It's a very different lecture to the other ones. So, okay, I'm just thinking. Let me ask you another question. What's an eruption? Anyone?
When the teeth grow into the space because there's nothing to occlude on.
Okay, but that's fine. But overruption means, give me a bit better now in terms of in relation to occlusional plane, right? We're looking at the occlusional plane. So eruption means what?
There's no opposing.
There's no, I'm sorry, no.
There's no opposing tooth.
Yes, I know, but if you say overruption, there's gonna be a reason. When you say this tooth is overrupted, how do you know that the particular tooth is overrupted in relation to occlusional plane? I'm giving you a hint here. Anyone else? Unopposed teeth, yeah, but I don't know. But when you say a tooth is overrupted, how do you classify overruption?
The length of the tooth and the position that it's in.
In relation to what?
The
Lip
bone.
line.
Lip line. Mhm.
Dr. Sarkis, we have a few comments. Somebody's
Yeah, I'm
written
looking, but
condensed.
I need an answer. You see, what I'm trying to make you think is that when you say something's overrupted in relation to what? If I say this plane is flying in the sky, occlusion plane, okay. Mikhail Grigorev. Mikhail, very good, very good. Occlusion plane is your reference line. So when you describe an overruption, it's going to be in relation to your occlusion plane, correct? Does everyone agree here? Yes or no? I need an answer.
Yes.
Yes.
Yes. I need to go next one. So let me show you the next image. So what do you think? Which one's overrupted? These are separate images of upper and lower arch. Which one appears?
The lower premolars.
They appear overrupted. Okay, that's a good possibility. And over here, there's the implant supported bridgework, right, from 4.2 to 3.2, as you can see. It's been done 2 years ago by a specialist colleague. And the patient presented. Her main concern was that, what would be her concern? I'm just curious. Have you had this
Can't
patient?
eat.
I'm sorry?
She can't eat.
She can't eat.
Chew properly.
Chew, yes, chew. And why do you think she can't chew?
Because there's so many interferences. Well, each of those will put a plane that will deviate the jaw, and so it doesn't feel comfortable to bite.
Very interesting. Dr. Howard, I'm going to put you in that spot. I want you to just hang in there. In tango, we say you're going to do suspension, so you're going to stay there till I decide.
Yeah, I'm suspended.
So I'm suspending you in that position. Stay there, please. That's a very important point. I'm going to just stay there, please, doctor. Okay, now I'm going to the next one. So Nimesh mentioned about lower molars erupted. Also, well, I think other colleagues mentioned, and Mikhail also mentioned that as well. Thank you very much. It is overrupted. There's no question about that. What do you really see when you look at this patient functioning? I mean, what other tests would you do?
Maybe a piece of wax to see how they actually occlude.
That's a good point. That's right. I'm going to bring you back to the first image, and I'll go back again. That's the first image, remember? So you start to think what I'm talking about, right? Now looking at some of the other images, correct or not? I'm going to go back now. I'm going to go back now. Let's see how this unfolds. So in other words, what else would you like to see from here? Like something else like to see. What else would you like?
Back, maybe some upper back teeth would be nice.
X-ray? How about some X-rays? Would you agree? X-ray? Let me show you some X-rays because there's a four. Here's the X-ray. What do you see? Jesse, go ahead.
Dr. Sarkis, we've got a comment from Mikhail. He says, no posterior teeth contact. Does she bite on the gingiva?
Very interesting problem. Well, the answer here. What do you think?
You can see all the drifting, probably from perio and also from the occlusion as well.
Right. And the question was by Mikhail, does she bite on gingiva? What do you think she does? Does she bite on
Yes, he does on the upper.
Exactly.
But that looks like a top. It looks like an upper tooth, but it's actually the lower tooth biting up.
Exactly, right? So we talked about, it appeared to Dr. Nimesh that there's a partial denture. It's very true. It does appear that way. It's very tricky, okay? So, look at the X-ray, right?
There's a noise in the background there.
Can we mute Nadia?
No, on the screen.
Can we mute someone?
At the bottom.
Can we mute?
The computer itself. There's a
Yeah, sure.
Thank you.
speaker icon there. Just
So-
click that one
On the screen.
Let's
on
think.
your computer.
Yeah, let's think about this. Okay. So, what do you think of the X-ray? What does it give you? So, if you had to combine that one and this one, what do you think?
The lower premolars are actually dumping backwards because of the bites. Looks like the force is just, they've got underlying perio and they're just being deviated.
All right. Okay. Fine. So the question, I'm with you. I think I want to ask you a question. I mentioned something about the implants here. Do you remember the question I asked? How long were these implants in place?
2 years ago, you said.
2 years ago, right? 2 years ago, they were placed these implants. I mean, what do you think? Is that the right treatment for this patient? I mean, in this situation? Think about it. Don't have to say yes or no. I just want you to think about it. I can see the midnight shift. There's a lot of things happening here, Mikhail, when you have a periodontal case. I'll talk to you. I'm going to the next one. Okay. So what do you see? Same patient.
It looks like that bite's actually locked in, that there's no ability to move laterally.
Mm-hmm. Mm-hmm. Mm-hmm.
Dr. Sarkis, Mikhail says midline shift anteriorly.
It's okay, I accept that. That's not a major concern, but I can understand that. I want you to think differently. I want you to really think very different. This is what we teach at the college. Because by thinking differently, see, when I talk about a midline shift, this shift, that shift, I'm not pointing you to aesthetics. I'm talking about function here. I mean, what's the real problem here? What happened here? I mean, can we go back and try to
Just collapsed.
collapse?
Collapsed bite.
Right, that's right, collapse bite. But when you think about it, how many teeth do we need for optimal function?
12.
Well, how many occlusion units do we need for an optimal function? Jesse, you should know that. How many occlusional units, occlusional pairs do we need? In other words, from what to what, if everything's good, it'll be okay.
6 to 6.
You need 8 units.
And which are
Mikhail says 10.
10 units. What's a unit? Where you count as 10 units? Like chewing units, right? Chewing units. So 10 means like premolar, Mikhail? Is that what you mean?
I'd like 6 to 6
So-
at least.
Okay. Right. All right. You see, shorter than large. Have you heard of shorter than large? SDA. Have you heard of it?
Yeah.
Right. What's a shorter than large?
Well, this top arch is a shorter dental arch. It's only 5 to 5.
Well, it's 4 to 4, really.
4 to 4. Well, yeah, 4 to 4.
Okay, that's on the upper arch. What on the lower arch?
Well, the 3/6 is non-functional. I mean, it's biting on the gums.
Okay. Okay, Mikhail, I'm coming to your question. You said 10 to upper lower second premolars. I agree. But when do you think a shorter than large with 10 upper teeth and 10 lower teeth will work okay? Under what situations?
You would need 4 occlusal, 4 pairs symmetrical or 6 pairs asymmetrical.
Sure.
Dr. Sarkis, there's another comment. Class 1 occlusion.
Class 1 occlusion, right. Okay, class 1 occlusion. That's a very good point. Who said that? Choi Lee.
Lin, yeah.
Pauline.
Very good. Class 1 occlusion. Okay, and who said that? Can someone remember? Choi, would you mind telling me where you got that reference from? That's very good.
What I meant is that, if you don't have adequate occlusion with your anterior teeth, like if you have a severe overbite, then you don't actually have any occlusal stops anteriorly, essentially. Okay.
I think class 1 occlusion is the right answer. And I'm going to give you an answer why. You see, one of the important aspects of doing dentistry, they did a lot of research in Netherlands, Dutch population, and also in Tanzania. They looked at Kaz's group and his predecessor's cohort group, examined over 700 people, and they realized that when you have a really good periodontal support and class 1 occlusion, premolar to premolar, second premolar, now it's 4 occlusion units, which is occlusions as chewing units on the premolars, are sufficient to maintain, normal teeth oral function. And they did lots of measurements. The problem is that in this particular patient, with extreme shortened dental arch, which is less than 4 occlusion units. But the other real problem is that in this particular patient, we have a periodontal disease. So the lack of bone support for the teeth, we have a secondary occlusal trauma, we have drifting of teeth. And the scenario of placing the implants in the lower jaw is actually kill the patient immediately. Am I making sense? Because there's no posterior support. And the implant there is absolutely useless. So whatever the money should spend to get the implant down lower anterior is a totally waste of time and waste of money. Am I making sense to you? So treatment planning at the time never thought of the future consequences. So the dentist only placed 2 implants to replace this gap because as far as he's concerned, it's fixed the problem. But that in itself has caused other problems that we need to look at. So we come back to this situation. Can you see the problem that there's no real posterior contact at all? And because the periodontal is total collapse, the only thing she's really chewing with is the implants and the upper anterior teeth. And she was told that when you come back, we can do some implants in the back and we can build this, but the old treatment plan is an issue. So how would you go about restoring this case? Let's say, don't worry if you do implants, you do anything else. What would be your aim in trying to restore this case?
You'd have to open her up a bit.
How would you do it?
From the top down.
How? I don't care, but how?
Maybe with a metal denture on the upper.
Mm-hmm.
Because you've got to test the system. You can't go in there with implants.
Well, somebody did before.
Yeah, but she was missing teeth in the anterior quadrant. The anterior wasn't the problem, it was the posterior.
With a partial
It would have been better to give her back teeth and then build it up or put a denture on the bottom than it would be to, I would have spent my money down the back.
Okay, let me ask you another question. You mentioned about TFAR, you mentioned about TFAR sliding backwards. Did you say that to me?
Yeah, collapsing, yes.
I said, just can we suspend you there for a time being, correct?
Yes.
Right. Why do you think
it's just gone splat?
This is going backwards.
It's the occlusal force that it's actually wedging the two apart. That it's not meeting in the right class of molar relationship or premolar relationship.
Fair enough.
So it's actually wedging in between and levering it back.
Okay, question. I'm just now, please stay there, Dr. Howard. Is Izzy here? Where are you, Izzy?
Yes, Sarkis, right here.
Good. Are you following this lecture or not?
Hi, Sarkis. Apologies. My mum's unwell, as you know, so I just.
Oh, very sorry. You're just coming. That's fine. Don't worry about it. Okay. Okay. So what I'm trying to tell you is that what I would do, and you want to open this up with a partial denture. So how would you open up the partial denture? Every tooth is mobile here. How would you do
it? The top ones are mobile.
Dr. Sarkis, there's a comment.
First, we have to figure out the prognosis of all the teeth.
Okay, so you've got underlying perio, and you've got occlusal interferences that are doing your force that are making the perio worse.
Okay, all right. Let me ask you. I've got a very interesting. Anita, here's something for you. I accept what you say. Let me give you a scenario. I'm going to say all the teeth, they have poor prognosis. Okay, you can't save them. How would you fix the problem? What would you do to restore this? What would you do?
If all the teeth have poor prognoses and we've decided to, we've deemed them for extraction, after that, we would have to present the two options, which are either removable or fixed options. With the fixed options, we would go with the all-on-4s, potentially, depending on whether the patients are maintaining their oral hygiene and everything like that. That's what I would present.
Okay, my question is a very specific question. I thank you for that. Is that how would you, when you say open, Jesse, you're gonna have to open it up. That's very good, and that's been confirmed by everybody in the lecture room. How much you think is correct in a vertical high we need to restore? What would you do this? How would you do this? How would you know how much you want to increase? Mikhail, I want to answer from you here. You came with a partial denture, so I want you to talk. Just talk straight away. Don't worry about writing, just talk.
Dr. Sarkis, we've got another comment from Genius who says bone loss, mobility, and incorrect occlusal force.
We discussed that.
Okay.
We discussed it, and that's acceptable. It's been discussed and it's mentioned. Thank you very much. But so how would you do this with a partial denture? I just want to know. I would understand that, but how would you do it, Anita? Understand, ideally. Dull technique, open the bite is, okay. What was my criteria for dull technique? Sean, talk to me. You have a teeth with periodontal disease. How are you going to open the bite with dial technique when the whole occlusion is collapsing? I mean, it's an idea, but how would you open the bite? Because what happens if you go and you open the bite, what's going to happen to those teeth? Where are they going to go? Is it going to be north or south or east or west? Where would they go?
South.
You pick a time. You pick a direction. I'll tell you which way it's going to go. So dial technique is good thinking, but it's not
Practical.
Not practical. Anybody else?
But what's going to happen? I mean, if you try and ideally, what would be good is to put back teeth on the top and continue the occlusal plane, but then you're going to get an interference from the over erupted lowers, because even if you got it right, there's still more over erupted than the occlusal plane.
Okay. Lillian says it's not ideal to discuss treatment without looking at the patient's profile. Okay. I will come back to that later, but let me give an example. Okay. What do you think the patient's profile will look like based on the intraoral images? Yeah.
Using a linear gauge to identify the point of first contact.
So it's a class 2 div 1. So they'd have a retrognathic mandible.
How do you know it's a class?
Probably.
How do you know?
What do you mean, how do I know?
How would you know it's a class 2 div 1? How would you know?
I don't know. I'd take a Ceph.
Actually,
but that, you know, that I'm different to other people.
Okay, but
I'd mount a cast. I don't know.
What is the Ceph here? Because if I bring the Ceph, I have to do the other images, which is going to give away. So how would you know? So we need to answer one thing. Okay, shown compass on palatal upper anteriors, take out the teeth that are hopeless. But again, if you do the compass on the upper, these teeth have drifted forward. They have minimal bone support. You had anything parallel on the compass of here, it's going to go either side, south, west, north, or east. Okay, it's going to go somewhere.
So, Dr. Sarkis, if you're going to need extensive bone grafting?
Yeah, but darling, before you do all that, you see,
you need a plan.
The reason I'm trying to say this to you, because this is what I get from the patient when they refer to you, or they find themselves here. They got all these things being said to the patient. So I have to try to unravel, trying to maintain everyone's, status quo to give the patient the right information. So if you say the patient is bone grafting, basically I need a bone graft. So I have to explain to the patient, can't do that yet. And this patient came exactly like that. She was so confused.
How about treatment dentures?
But how are you going to build to the occlusion of vertical dimension? How are you going to do it? Michal said partial dentures. I agree. But how are you going to do it?
But the problem is the lower over erupted posterior teeth.
Don't worry. How are you going to do it?
Cut them off. Take them out.
No. How are you going to do it? Does anyone understand my question here? If you don't, please, I'm happy to rephrase it again. I'm getting a glass of water. Just think for 2 seconds. I'll just get my glass of water.
How are getting exciting? Heavens.
So, how are we going to restore this patient's occlusion vertical dimension? What's another word for occlusion vertical dimension? Give me another word. What's an occlusion vertical dimension?
The height of the lower facial structure.
Yeah, lower facial height. What's another word? What's another word?
Video.
Jesse? And Mikhail, you better come in and talk.
I'm not sure.
Jesse, you're not sure, darling?
Something to do with the TMJ? I don't know. Out of my depth.
Fair enough. So introductional space, I agree with that. That's another way. Okay, why is occlusal vertical dimension or the facial height, another word is lower facial volume, important? Why?
It's in balance.
Okay, Dr. Howard, fair enough. Anybody else? Come on, guys, I need someone. Okay, I'm gonna.
There's some chat comments from Linian Shi.
This is DMD. Does this patient have TMD? Do you expect it to have TMD?
Yes.
How many say yes? We have about 50 people there. How many say yes?
Genius
Yes.
says yes.
Okay. How many say yes? Just say it.
Yes from me.
Got TMD. What else? Uh-huh.
No from me.
Oh, why?
I don't like it.
Oh my God, this is funny.
Sean Wong says possible.
Possible. Headache. Sorry, when you say headache, is it because patients got a headache or of course they get a headache here? Chronic pain. Does the patient have chronic pain?
Does they? Do they? Did you tell us?
Did I tell you she's got chronic pain?
No.
Did I tell you she got TMD?
No.
Then why are you presuming she's got TMD?
Because I don't like the interferences that are deviating the muscles.
Does interferences cause TMD?
Well, according to you, no.
No.
Choi Lin Lee says no.
I'm talking about a locked-in occlusion.
Okay. Sean, tell me how you're going to do with regaining the occlusion of vertical dimension.
Can I try?
Mm-hmm.
Can we take that implant bridge off in the lower fore anterior and put something temporary there to play with the height there? I don't know, on the facial of make a temporary bridge there, maybe put.
Okay, let's talk about this because this is important.
Yeah.
Okay, Alexander Meyer says TMD is complex syndrome that does not correlate 100% with malocclusion. Well, I'll say 200%. Okay. Let me ask you a question. In your practice, when you see patients with full dentures, how many have TMD? Same ratio as the general population. So it's got nothing to do with occlusion. Okay, nothing to do with it. It was an old concept of Ranford and Ash back in the 60s and the early 70s who talked about occlusion differences causing this, but it's been refuted many, many times over. But anyway, we won't talk about that. Let's look at the RPG. So what do you think on the RPG of the condyles? Why? I mean, what's so, is it, they're normal or what?
Yeah.
Are they normal looking condyles? Yes or no? RPG show condyles too condensed.
Condensed.
So you're saying they're not normal, Genus?
Yep.
Yes.
Who says they're normal and who says they're not normal? Come on, guys, make up your mind.
Not normal.
Not normal, I said.
Not normal.
Yeah.
What's a normal? What's a normal?
John says pretty normal for an elderly person.
Very good. So what's a normal?
They look pretty condensed and flattened, so I don't think it's normal.
So what does flattening mean? Imagine I'm examining you. Imagine you're being examined.
Well, we've just failed.
No, I'm not going to fail anybody. I want to help you to think. That's the whole aim of the college. This is why you start thinking, because you got those 2 or 1 day shitty courses, you learn nothing. That's what I'm trying to explain to you. You want to learn real dentistry, that's what we teach. So the question is, if this is flattened, very well said, and I agree, it's flattened. Why is it flattened?
Shortening of the masseter.
Okay. Look, fine. But what would the reason for flattening? Isidore, how about you have a go?
Over closed vertical.
Hmm?
An over closed vertical.
Okay. If this patient had perfectly good teeth and overclosed vertical, it was class 2D2, there's a good possibility that you'll accept going like this, because it's taking a lot of load, and when it's loading, there's a process of adaptation, and adaptation is normal physiological change. Okay, because it's loading, it's adaptation. So my question is, I'm coming back to the same one. How are you going to restore the occlusional vertical dimension? Nimesh, your answer was okay, but it's an extreme answer, but it was okay. What's another simple way of doing things? What do you do when you try to open a vertical dimension? You have to take some measurements. You took your models, or you did your scans. Then you're going to take a bite. Where would your bite be? Where would you be a reference for me opening up the vertical dimension? Where do you want to be? Where's your condyle going to be?
Dr. Sarkis, there's a comment from Alexander. Condyle responds to pressure by resorbing.
Resorbing is not the right word. It should be remodeling. It should be remodeling. Remodeling is a response to a function. And condyles are not made of steel. They remodel. If the condyle or TMJ didn't remodel, every time you do a new restoration, new crown, your patient is screaming with pain. You understand the fact that there's a body that tolerates all this change. Okay, we'll talk about it in college one day, but if those of you who want to learn how to understand the function of the stomatographic system, which is the mouth oral physiology. But I want to really, from this group, as an experienced group, I want you to come up with an answer. How and what would you do to open the occlusional vertical dimension? Nothing significant.
Sean Wong also said
nothing. Huh?
Sean Wong also said upper partial temporary denture to open her up.
Where would you do it and how would you design it? I know, but how would you design it? What would you do?
The problem is the lower over erupted premolars.
Okay,
you can't make a denture there while those are that long. So you'd either have to remove them or cut them down.
Would you remove them or cut them down?
I'll probably cut them down or do something where you could.
Genius is saying, is there anything significant in the medical history?
No, none. Okay, and use that as the height. Hang on, could you take protrusive record, which gives the connection of the condyle? Use that as the height of the posterior teeth in centiculation. Look, okay, Anita, I'm going to ask you a question. I want you to answer me by the audio. Where have you studied the occlusion? Whereabouts?
I'm actually still a student. So I study at La Trobe University. It's just a bit of reading I've done into, and that's my understanding of it.
Okay. You're currently doing pros? Where are you studying?
I am doing dentistry at La Trobe University, Melbourne.
Okay, you're doing prosthodontics or you're doing undergraduate?
Undergraduate.
Okay. And you studied somewhere along the line when you do the anterior measurement, you can see the condyle inclination. Okay. Because you see, let me ask you a question. That would give you very small part of the equation, really. Okay. Which year are you in?
I'm a 50th year student.
You're a 50th year student. And did you read this or your lecture told you?
No, this is a bit of reading I've done outside of my university.
Gotcha. Where have you read? Which literature have you read?
From memory, I think I read, I was referring to a bit of Schellenberg and just a couple of our articles and YouTube videos I saw.
Okay, you probably saw you read Dawson, did you?
I think so.
I think so too. Okay, let me explain to you. I mean, I commend you, but
No.
yes.
CPD करता थोड़ा देर बाकी.
Okay. My question would be, can we move? My question would be, Sean, is it when you, okay, see, what I want you to start thinking in terms of the anterior teeth and mobility of about 2, okay, 2 or 3, all right? I was hoping someone would measure period chart because this is all new patient. I didn't take period chart. There's some photos. Going to come back for a regular, some periodontal charting and overall risk management, risk assessment. So I don't have a period, but the mobility is about 2, okay, about 2. So if you do any protrusive records, you're actually not going to get condyle guidance because they're just totally different. As a matter of fact, condyle guidance will give you a different record because it's on the posterior determinants of occlusion, not the anterior determinants of occlusion, right? It's a bit complex, but don't worry about that. I won't confuse you. But that's not the right answer, but you're thinking, which is great. That's the right answer. So when you restore the occlusion vertical dimension, where do you put where the condyle should be, that's your reference point. Somebody can help me out with this. You should know. We're still on one case. We're going to finish on one case because I want to discuss the other 2 cases next few seminars. So where would your reference be? Anita, you should know this. As an undergraduate student. So in trying to open the bite, where would your condyles be? How would you do this? How would you open the bite?
As I stated earlier, so just in the superior anterior position of the condyle, which is the centric relation.
How would you determine centric relation?
So some of the methods include, for example, by manual manipulation and asking the patient to swallow, so then the condyle is in its most.
Okay, that tells you the the retracted condyle position. So how much would you open?
That's the part I'm not too sure about. I think we get enough teaching. Yeah.
So somebody, very good. No, I'm very happy with you. Stay there, please. Dr. Howard, you can't wait to answer. Come on, come in. How much did you open?
To the M position.
No. How much would you open? Come on, guys. How much would
4 millimeters.
Why?
Jesse says 3 millimeters.
Yeah.
Okay.
Because you've got to get the interference of the lower teeth that are hitting the back that are making them splay forwards.
Jesse, why 3 millimeters? I just want to. Huh? Khan says to bite plane. That makes pretty good sense to me, Khan. You're thinking, I like it. So why would Khan be close to the mark to a bite plane? Is there a rule?
Would you look to open 2 to 4 mils lesser than the physiological rest position?
Or the speaking position?
What's a physiologic rest position in this patient? Do we know?
It's probably 6.
You could measure that from the nose to the chin and get the patient to make an M sound, where their lips are just touching.
And what about the patient's face move? Would you lose 2 or 3 millimeters of your measurements?
What about the Shimbachi?
Okay, talk about Shimbachi. That's not a bad idea. Go on.
So it's CJ on the top to CJ on the bottom, and it should be 19.
19 millimeter. Okay, that could be a way. I mean, to me, it's not.
That's Carlson, is it?
No, it's Shimbachi. You're right.
Yeah.
He died recently, last year, I think 2 years ago. He died a year or 2 ago. He died. Okay. I want more. Like, I don't know. This is every day. This is like this old free patient come this week. I just put them up there.
Why don't you just get some bite wax and try the system? So you do that, and then you put another layer and see how it goes. You could start off with 4 because that's a nice figure, and then you could take it down or take it up compared with how they feel about it.
Okay. I'm going to just throw something at you, right? It's not going to throw like a little span in the wheel, right? What do you think of this tooth here? Which one's this tooth? Nimesh, what was this one?
That's the 4-4 or 4-5.
4-5. Okay. So what happens? You so diligently pointed out the 4-5, Dr. Howard. That's going backwards, right?
It's heading backwards. And I mean, whatever you try and do, it's going to be in the way. That's why I said you either cut it or you take it out, because it's interfering whatever you do. If you try and put bite blocks on the top, it's because if you need 4 millimeters, it's 6 millimeters too long. It's already touching the gum on the top.
I like your measurements, like that. You know what? People don't know, Dr. Howard is the best cook. When Dr. Howard,
thank you.
Okay, like she knows how to cook. And my wife doesn't like going anywhere, but when Dr. Howard cooks, she'll get in the car with me and come. So I know that for sure. And Dr. Howard is very, very great on the right ingredients for the recipe. Dr. I'm not going to argue with you in that, but acrylic, so we got there's other man saying do acrylic denture with open position, then cut back until patient's comfortable. Sure, that's not a way. There are many ways, are there? Is that correct? Would you
agree? Ways.
Many ways. You agree that there's many ways, or are you happy?
There's many ways.
Okay. So if the patient is the right vertical dimension, how would you test? First is comfortable in the bite. What else is important in testing? Dr. Howard, let the other ones talk just for 1 second. Alexander, Jesse, Sean, Anita, talk. Well, how else would you choose the correct measure?
There is a comment from Alexander. Do acrylic denture.
Yeah, I got that. I'll talk about it. Kevin, I did. Thank you. Thank
you.
So, talk. How else would you test the system?
Once we have figured out what our vertical dimension is going to be, we could try mock-ups potentially.
Yeah, but I mean, you open the bite, right? Okay, how would you know it's the right bite? They say I'm comfortable, but sometimes I can't speak. I feel like so what am I trying to tell you? So what would you test?
Dr. Sarkis, we've got a comment from Sean.
So the speech comfort is on part. The status is the other part. Facial height, right? Okay, very good, very good. If the patient is a stutterer, you have an issue, right? Think about it. So you're going to make sure the patient doesn't have a speech problem before you open the bite. Just let you know. That's another thing to consider. Okay. I think we covered Laura, but Dr. Howard, you stumbled on something very, very interesting, which I think needs merit, right? It's like your Sherlock Holmes thinking, which I admire all the time. Seriously, okay? Maybe you should rewrite the book. That's what I think. You should rewrite the book, maybe Sherlock Holmes. What do you think of that?
Good idea.
Good idea. Okay. So what I like to do as a part of my diagnosis is try to go back, find out what actually caused the problem. What if it's actually, you said mandible is locked in, the 4-5 is going backwards. So when you say something's locked in, what happens? How does the mandible come in locked in? Sean, I want you to talk about this. You understand? So mandible is locked in. How do you lock in that position? So what I want you to tell me, how do you lock in here? How do you go locked in? That's pretty locked in. It's like an alligator bite, isn't it? Like if you were in the river up in Cairns, you get hit by an alligator and then does the death turn, right? You're going to really get you, right? This is locked in, guys. So what am I trying to tell you? The question was, Sean, that patient is locked in here. Okay, how did the patient come all the way and go locked? There's a reason, like it's you. Okay, but how did the patient come into lock in there?
Losing the back teeth that it's just falls in on itself.
Back? The patient moved the jaw back, or the patient moved the jaw forward, or went up or down? Where did it go?
It went backwards.
Jaw went backwards, or jaw came forward?
Yeah, so it's got something to do with guidance, right?
Yeah, so what's guiding?
Well, there's no canine guidance.
Who cares about canine guidance? It's an intercostal position. What's guiding position there?
Well, it's the mesial of 4-5, isn't it?
4-5, right.
Is guiding it.
guiding a curve. So if you had to determine the vertical dimension, what would be the most ideal way for you to test the system?
Well, 4-5 is the guide. But it's over erupted, so you can't use that because it's in the way.
Okay, Sean saying build up 4-5 MIP. Interesting. You see that there's a real problem with education, and what the students been taught sometimes is not what actually it is. That's why we have the college. See, what I would do in this situation, you got to think like a Sherlock Holmes. I would go and see if I can establish natural contact with this patient.
Then you're coming up to 9 millimeters.
Who cares? That's a natural contact.
Well, that's where they want to be. That's where they want to be. Sometimes you start at 6 and you end up putting another millimeter, but you can't go 0 to 9 in one go.
Exactly. So I have established natural contact for this patient. So from here, doesn't matter what you want to use to maintain it. Am I making sense or not?
They can't tolerate it in a big amount in one go. You've got to increment it.
Not really. That's a natural contact. She actually bites and then just locks it forward. It's a natural contact. That's in RP. That's a retrograde contact position. RCP. That's exactly what she's supposed to be. So when you think about it, what's happened is that she's bites there.
But there was not enough support of bone for it.
You understand? That's how she was. And the teeth were further back touching here. So if you bring it back, it'd be touching here. Unfortunately, the primary occlusional trauma, which was the secondary occlusional trauma initially, and then primary occlusional trauma because of the lower. I mean, there was nothing done to stabilize the occlusion. All they did is to put the lower implants and it's integrated, and everyone's happy because they got paid. But the patient ultimately loses most of the teeth. So we talk about diagnosis and treatment planning. I mean, people tell me, look, just tell me how to do it because I know how to diagnose. Well, this is diagnosis and treatment planning, ladies and gentlemen. So I talk to you about how to think and what the eye cannot see, that mind cannot recognize. That's what I'm talking about. Because everyone has an opinion, and I accept it. But really, in many ways, I mean, can you see what I'm talking about? So we need to think of this patient who's about 59 years of age, that there's a reason why she's here. So if I have a natural tooth position, that's exactly where I'm going to build this patient, because that's my best reference point. Are we all clear? Any questions on this or not? Yes or no?
How
No,
did you
it's all
establish
good.
that contact, Dr. Saki?
Say it again, please. I didn't hear you.
How did you establish that contact?
This? Well,
yeah.
Somebody mentioned leaf gauge. Okay, why would you do leaf gauge? Because Dawson uses it, and I know a lot of the American schools use it. I'm not sure if Melbourne School uses it. I don't believe in those things. I just don't. Because I know how much I need to open. I have an idea where things will be. We'll teach you at the school, by the way. We'll teach you at the school. And irrespective, it's a natural contact, you know. We can chop out that premolar a little bit here. That's not an issue. Okay. So having established this, what else would you do here to maintain that? Would you use a partial denture? What else would you do?
What I said, take the implant bridge or probably do some temporary bridge there.
Okay.
Build it up. Build the lower.
You can even bond the composite on top of the implant porcelain. I don't mind if it's gonna stay there. If eventually we're gonna replace that bridge.
I'm not worried about the implant bridge. I mean, what's the issue here, really? What's the real problem here?
Perio.
Perio and
Lack of posterior support.
right, occlusional instability. Okay, so you need to provide splitting and stabilization and maintain comfort if you're going to do anything else. So the aim would be to restore the lower facial volume, vertical height, and then build your implant prosthesis while you're maintaining all that. There's many ways of doing it. You see, the patient will not wear a partial denture. That's the whole reason the whole mouth follows. You're going to find other ways of looking after the patient. So when you do this course, you learn how to think on different modalities and what's the best treatment, number of options, not just one thing, what you know, there's other options available. You're going to think outside the box.
Dr. Sarkis, what would you have done if the patient said that they didn't want to go through all of that treatment?
Which treatment?
If they didn't want to start off with the building up and then opening up the bite, like if that was all too much for them, given the amount of dental treatment that they'd already
No, but they wouldn't have turned up for the appointment with the specialist. She wants it. She wants that treatment.
Okay, let me ask you something, Jessie. What would be consequences of no treatment?
all on four.
But you don't understand. You
full dentures.
Excuse me.
She's going to lose them all.
Jesse, you wait. You're making a statement here, fair enough. But if you blob out all on four to the patient, how are you going to do all on four? How?
I'm not saying that that's, well, I'm a dental nurse, so I wouldn't do that, but that's what's happening out there in the real world, is that patients will come in.
Right. If they're doing all on four without doing the underground work of
doing the underground to do the,
how are you going to do the rest?
Well, more often than not, they're not even given the options. They're just.
That's right. And we see them here.
Yeah.
Then the implants are placed all incorrectly, and we have to go back in, take them all out. There's $100,000 of redoing all this work.
Yeah.
Okay, and then that becomes major litigation issue.
Well, that's why I ask, how do you convince them that this is the better option than going down the quick and easy cosmetic fancy makeover thing?
It's not quick, easy. All of four is not a quick, easy step. It's actually quite complicated. Very complicated. It's not easy. It's commercialized, but it's not easy, I can tell you. The question you're asking me is that, how do you talk to the patient? Is that correct?
Correct.
Good.
And how do you do it as a general dentist?
Okay, when you do a 2-year diploma course, I'll tell you. Can't tell you in 2 minutes. And that's what it's all about.
Recognize and refer.
No, we'll teach you even that. You first recognize and refer, but ultimately you'll be in a really good position to be able to at least be part of these cases and treat them. That's the whole idea. The most important thing, Jesse, is to understand the possibilities and limitations of the treatment. And the patient goes and does all on four, and I see them all the time now. During COVID, I've seen a lot of these cases coming out failing. Okay, if the vertical dimension is correct, they can't speak, they can't eat, their function is compromised, and there's too many issues. So what I'm trying to say is that people today are not stupid. They know how to read the literature. They know how to place. I see this every day. I've seen 3 cases like this week. I mean, let me just talk to you about someone that said to me about, what about the facial profile? Well, what about the facial profile? Dr. Howard, is she class 2 or class 1?
What, in the where she started?
Yeah.
It almost looks like she's, it's difficult because they've displayed upper teeth. It looks like she's almost a 3.
She's class 1. She's class 1 on clothes. But that's not an issue for me. It doesn't matter. To me, I don't care. 1, 2, 3, 4 bar. I don't care. It doesn't matter. The issue is that, what's his middle picture tell you? What do you see here?
Collapse bite and the low facial
before.
height being compromised. Yeah, the before one. But the after one, as soon as you actually put her where she should be, it just looks a youthful face. So the diagnostic
relation with the tooth contact.
She looks 10 years younger.
Exactly.
That's what I understand.
So does it make sense? So when you explain the patient, you show the
And
picture.
the chin goes down and back.
Okay, that's where you're going to restore the patient. Is your reference point. So if you take the teeth out and make full bench, you lose all these lovely reference points. Doesn't make sense to me.
Yeah, absolutely.
Never did, never has. But university they teach you this because they don't know either. That's really the sad part about it. That's what the college is made to bridge that gap. It's very important that people understand. Very important to understand. You have a mentor that actually goes through your cases. Robbie, well, Robbie, you there?
Yes, Sakis.
I'll
I
cover
was
that.
there, yes, sir,
You
yeah.
hang in there, Robbie, hang in there. We're going to cover that patient. Look, so here's the next one. She's actually biting here, okay? And you can see the occlusion collapse. And look at this one. She's still biting. Look at that. See, one of the things is that when you look at dental rejuvenation, is the nasolabial fold, it almost becomes vertical. It's the collapse of the facial curtain and the buckle of the belt. And you can see the same problem. So you can't even restore this case unless you restore the regulation. Am I making sense?
Yes.
It's almost 9:20. I was hoping to go patient 2, but this is the next one. So any questions so far? It's been a lovely, by the way. I really enjoyed this dialogue. I hope you like what I did today. I hope you got an idea what I'm talking about. But he's age 50.
It looks like a meth addict.
No, he's not. He's not a meth. It was meth who told the difference. Major perio and fear of dentistry neglect. I've seen those patients this week. Like what's today? Wednesday? So Monday, yeah, this week. One patient I saw about 2 weeks, but 2 patients on this week I just came.
That's the hygienist delight.
Well, yes, we'll talk about that. That's next visit. So we'll talk about some of this. So I'm going to conclude today. I think we've had enough. Is there any question you have that you want me to answer? But coming back to this, we talked about the college, right? We talked about why is it important, because you have this whole team of people who are going to make you think and you're going to challenge your thinking. The only you can advance as a practitioner is someone actually challenges your thought pattern. Not because someone agrees with you, but you need to come up with a good logical treatment plan and back up with the literature. You start reading and understanding, and you start thinking about it. That's how I became one. And so that's why, I talk to a lot of dentists. They do these 2 or 3 day courses. There's only 4 courses for a couple of days. The trouble is, it should be called carpentry. How to be a dental carpenter. That's a better course name. Because if you know how to diagnose, you will know how to put it together. I can tell you. I can teach a monkey how to drill a bone for an implant. Okay, but where to drill a bone, that's you're going to be a doctor. That's very important. And this is what we teach. We make you think from the start to finish, how to think, how to talk, what to say, when to say, how to get information, how to train your staff, the philosophy of thinking, also philosophy of living as a practitioner, as a dental practitioner. Okay, we will talk about like people ask me composite of posterior courses coming up. So please go in there and register your name so that I can get this organized for you. We're just getting participants. So it's just been crazy times to cover it. And then we got the next one, piece of surgery. Okay, those who want to be advanced stuff, how to do advanced surgery. Okay, we go into that. And then we got the the problem solving using composites. And this is really applicable to this lecture, which I get, because I would actually build this patient with lots of fiber bonded composites and build it to the level I think she should be. And really, yes, go ahead. So, in many ways, we make you think, and there's more courses coming up. There's over 30 courses coming up. And then we combine these courses as part of the program, but you actually get more extra benefits by doing these courses. So I hope I was able to answer all your questions. That it was
Dr. Zarkis, Alexander is asking, so finally, what was the treatment? plan for her.
And she hasn't come yet. She's coming for a consultation. So this is all the thought process goes in my mind before I consult the patient.
So you talked to her, you went through it, you said you got to raise the bite. How did she leave, and what was her expectations after you enlightened her?
She hasn't come for the second consultation.
What is it? Because it's expensive? She didn't understand. She didn't want what you want. What's the gear?
Initial examination, we do diagnostics, you get data gathering, okay? So we take the x-rays. So I sit in a Posterior chart, and she didn't have time. I took the image so I can have a look and make a decision which way we're going to go. And I had some time to think about. So when she comes in, I'll be present my initial assessment to her and give her some sort of solution as to which is the best way to go. And then she can think about it. So it's not going to be that quick. It's taken another 30 years to get here. So you can't expect to fix it within a week. It's not going to happen. I know a lot of people like to find solutions.
And you can't have an answer on the day either if you haven't got all the diagnostics.
No, I think the most important thing is for the patient to own the problem. If the patient doesn't own the problem, who owns the problem?
You do.
No, you do.
Deflecting.
Of course I do. Okay. And you can't treat the patient unless they understand. As you make a treatment plan that's specific for that patient. And that is your, intellectual property. Okay. And sometimes I'll write a treatment plan and write what we're going to do. And patients, well, you're expecting we're going to do another dentist. And I get a call from another dentist. Now you wrote here, you're going to do this. What was that about? I have no idea. So it's very important that you think a good thought process in approaching your treatment plans. Okay? Have a contingency plan, have a backup plan. If it doesn't work, what would you do? It's a logical approach. So I was asking before I leave you, now thank you very much for today. Doctor, what is the rationale behind your treatment planning? So every time you treat patients, you think you're really great in taking teeth out for implants, just think, what is the rationale behind my treatment planning? If the treatment fails, what is my contingency planning? What's my fallback position? So in that, I wish you a very good night, and thank you for joining me. In 2 weeks, we'll have Garima, she's the endodontist. It's a really good lecture, so we'll join together. Thank you all. Thank you.
Thank you,
Dr. Sarkis.
Thank you.
Thank you.
Bye-bye. Bye-bye. Thank you. Thank you.
Thank you. Bye. Bye.
Thank you, doctor.
Thank you. Thank you. Thank you.
Thank you, Dr. Sarkis.
My pleasure. Thank you all. Thank you for joining us. I really appreciate it. That was wonderful. Wonderful.